Hello,
Hi, guys.
hello.
Hi
Welcome,
there.
Dr. Boockvar. So nice to meet you.
So
Hi.
nice to meet you. I'm sorry that we're running a little bit late.
That's okay. We will forgive you. Patient care always comes first. So
How are you? Hi,
we are
everybody.
good.
Hello.
Hi, Dr. Boockvar.
Hi. Well, thank you so much for joining us today. We're
Of
really
course.
excited to have some time with you to do this Q&A.
Yeah.
As you know, I'm Angel. I'm the founder of Brain Tumor Companion and Meningioma Companion, which is a peer-to-peer support platform for brain tumor patients and their caregivers at all stages of this journey. So today we have a bunch of my companions in the room that are so excited to engage with you and ask you questions. But first, if you could tell us a little bit about, who you are and why you chose to specialize medicine and introduce any of your team that might be with us today, we'd love to hear from you.
Well, thank you, Angel, and thanks for setting this up. I think one of the most important things that we struggle with is actually being available for our patients all the time. And there's just not enough of us and enough hours in the day to do that. So having resources like you're providing, I think are frankly incredible. So thank you. I want to thank you personally and professionally, as I have family members who struggle. And Cynthia Liapis is our chief nurse practitioner in our brain tumor program here at Lenox Hill Neurosurgery. I'm a neurosurgeon at Lenox Hill. We started our brain tumor program here at Lenox Hill Hospital about 8 years ago. We were fortunate. Lenox Hill Hospital is sort of, you may know of the hospital as somewhere where Beyonce delivered her baby or Chelsea Clinton delivered her baby, but they never had a brain tumor program. And so we were charged about 8 years ago of taking this very boutique, nice hospital and making it one of the world's best brain tumor programs. So I'm just grateful that we were able to recruit people like Cynthia. You may meet Tamika, who runs our clinical trials office, and all the staff to where we've become a top 20 neurosurgery and neurology program in the world in a few short years. So we're just thrilled to have access to these programs. This is the silver lining of the pandemic, right, Angel? That we now do Zooms, and it's like the easiest thing. 2.5 years ago, we may not have even known to do this. So again, I love that placard on your back wall. Love is all you need.
Yes. Wow. Good vision.
It is very good vision.
So, we have a bunch of people. We actually just had a sick brain tumor patient that they were all in with. So that kept us a little bit longer. But we're really here for you. As people check in, I'll introduce them, but we can go ahead and get started in the interest of time.
Sure. Well, thank you so much. We really appreciate the work that you do, especially in the research realm, and taking the time to be here with us today. A lot of us are fans of the show Lenox Hill, so we sort of feel like we know you a little bit, but we are very grateful to get to know you a little bit more. So I'll just jump in and start asking my companions to introduce themselves, a little bit about who they are, and maybe a question that they have for you today, and we'll go from there. So first up is Lisa.
Hi there, and thank you so much for your time with us today. I am 3 years post-craniotomy, meningioma brainstem. I was diagnosed with epilepsy last year. In 2001, I went through a laminectomy for a schwannoma on my spinal cord. So my question for you is, can spinal cord tumors affect the function of the brain?
So in general, no. The spinal cord is separate and distinct from the brain. Now, obviously, the nervous system is all connected. So it's somewhat of a tricky question. The answer is, brain function affects everything. Brain will affect the extremities, the spine, your bladder, stuff like that. If you had a schwannoma in the spine, though, that was removed, what level of the spine was it?
Thoracic.
T9,
T10.
Yeah, so technically your brain should not be involved. Anything lower than T10 should be involved. So it basically, anything from T10 below may be involved, but anything above T10, so that means your cervical spine, your brain stem, and your brain should be independent of that laminectomy for the schwannoma.
Okay.
Is that clear?
Yes.
All right. Thank you, Lisa. Next up is Kelsey. You're on mute, Kelsey.
Hi, all. Thank you so much for joining us and taking the time. I know you guys are very busy. As Angel said, I am Kelsey Knapp. I am from Frederick, Maryland. I am almost 3 years post-op with 98 resection craniotomy. It turned out it was a pilocytic astrocytoma. I'm probably saying that wrong. I'm still struggling with a little bit of positional vertigo, but otherwise I get along well. I do have NF1 that I've known about since I was a teenager. However, my pilocytic astrocytoma didn't show up on my MRI until I was well late into my 30s. My question is, since most of the tumor was successfully removed, in your opinion, what are the chances of this maybe growing back? I mean, I don't need yes, it'll grow back or no, it won't grow back. Just a rough idea in your opinion.
So first of all, pilocytic astrocytomas are generally slow growing. So they tend to be more of the benign type of glioma than the classical cancers like glioblastoma. So that's good news for you. Now, that being said, they can be in areas that still wreak havoc even though they're slow growing. So they can cause symptoms even though they're benign. So one of the questions I have for you is tell me a little bit about the vertigo that you're having. Is that something you've had since surgery?
It happened prior to surgery, and I do have epilepsy. Like, that was a long time ago when that started. My neurologist had suggested another MRI, and I kind of was like, no way. So they suggested other things like physical therapy, changing my diet, etc.
Yeah.
I did that for about a year, and I was like, all right, fine, I'll get the MRI. And lo and behold, that's where they saw a brain tumor.
Right. And so the answer is depending on how much is left from the surgery, they can grow very slowly. It doesn't mean we're going to do anything about it. But I just treated a 19-year-old. Then I want to introduce two people that just came in. Sometimes you didn't have radiation after surgery, did you?
No, sir.
So that's a possibility if it did grow back. You don't necessarily need more surgery. You can do radiation. And sometimes things grow and we just leave it alone.
Okay.
So, and we, of course, and Angel, if this is okay, I'm always happy to review these things. First of all, you're always welcome to come here. Now, I'm not licensed in Maryland, so I can't technically give a medical opinion in the state of Maryland. And actually, that's a disclaimer I'm saying right now, that this is more of an educational sort of meet and greet. I'm not technically giving anyone, because Angel, I see you recording this, I'm not technically giving anybody medical opinion because I am not licensed in the state which I am not in.
Yes. And none of us are your patients, so we are not your responsibility.
So, but of course, we would always, and any of you can ship us our films. I want to introduce you to Olivia and Tamika. This is Olivia Albers.
Hi.
Olivia came to us just recently from the Cleveland Clinic. She's our nurse practitioner in our brain tumor center. Of course, it's my birthday tomorrow. They decorated my office.
Oh,
Happy birthday.
And then
Happy birthday.
Tamika runs our clinical trials office. And Tamika and I have the longest relationship. We've been working together for 11 years since we were at Cornell. So again, I think I speak for all of us that anytime you want us to be actively involved, I'm always happy to do that.
Okay, thank you.
So-
I appreciate that.
Yeah, thank you.
Awesome.
Kelsey, did I
Perfect.
answer your question?
Yes, you did. Thank you so much.
All right. Thank you, Kelsey. Next up is Brenda.
Hi, thank you so much for doing this. My name is Brenda. I'm from Tucson, Arizona. I'm about 2 years post-op of a left frontal lobe oligodendroglioma. I have to say that in multiple sentences. Grade 2. I had 6 weeks of radiation in conjunction with chemotherapy, and then 6 months of maintenance chemo. Last December, I started having absent seizures. My question is, why is it that so many doctors confidently say that our symptoms are not related to the tumor, yet many of us from different states and countries have fewer symptoms or more symptoms post our craniotomy?
Every doctor is different. I think that there's a lot of, negativity. most doctors just don't have the time or the willingness. And I'm fortunate to have some of the best nurse practitioners behind me who, are independent clinical providers in their own right. And I think some of these support groups are really important for you to get the reassurance that what you're thinking and what you're seeing is actually normal. And I'll just give you an example, which is interesting. There's also a lot of sexism in medicine. So I just came from upstairs with a woman, this is a true story, who was 30. She had a baby. And 1 month after she delivered, it was a terrible story, but I just got it upstairs. She went into psychosis, and she saw a male doctor who automatically assumed that the woman had postpartum psychosis. She just died of CNS lymphoma, so he was wrong. She had a brain cancer in the brain.
Oh, no.
So there's sexism in that way, that there is, we all suffer from our implicit biases. So I always say that we have a saying in New York, of course, in the subway, if you see something, say something, right? And so, I just want you to recognize, to have the courage that what you're feeling, your body better than anybody. And that is really something that you should be aware of. And what I think we can do a better job is listening to the people that know their bodies best. I think, if you don't mind, I want to ask these guys who have just as much experience as I do in answering that question. So what do you do when the patient's, it's easy for us to say, oh, it's unlikely to be from the craniotomy. It's not from the brain tumor.
Well, just from my experience over the years, because I've worked inpatient and now with outpatient, we only meet that person at that time. We usually listen, I know as a group, which we do very well, we listen to the family and the patient. They know their body the best. We don't judge. And then we'll look at the family and say, well, how do you think that they're acting? Or is it out of their norm? So I think we do listen to the patient. Absolutely. I mean, we see the patient like, oh, they're just overreacting. They're not overreacting. I mean, you know your body the best. You know if something's wrong. You have that feeling. Sometimes you can't put a finger on it, but there's definitely something. And then we try and then reach out. Just like the other day, we had one of your patients, Nadia was doing, and she didn't feel good. She had a fever. Right away, of course, as surgeons, we think it's an incisional infection. So we told the patient, come in, and then we did a whole complete workup. It had nothing to do with the incision. It's something totally different. So then she went to a pulmonologist, and he was very grateful, because I spoke to him yesterday, that we did the actual complete workup as an outpatient to prevent her from coming into the hospital. So we do listen to the family. The patient wasn't really complaining too much, but the daughter was saying, no, she's not going to tell you the truth. So then at that point, we listen to the family. So we are very in tune, and we listen.
That's great.
Remarkable.
I'm really glad that you guys do that, because my doctor did not. I mean, he was a great surgeon, but he definitely, I had to go to 3 different neurosurgeons to even get an MRI. So
one thing I have to say with the group that we have here, we have excellent neurosurgeons, but again, they have excellent bedside manners, and they're very involved with their patients, and they listen.
that's amazing.
So important.
It
Thank
truly
you.
is.
Really very helpful when they listen to us. Thank you, Brenda. Next up is Deneen.
Hi, thank you for giving us this opportunity. We really appreciate it. My name is Deneen. I'm from Baltimore, Maryland. I had a golf-sized meningioma removed from my left frontal lobe in August of 2019. I developed hydrocephalus, and as of March 2021, I have a VP shunt. I've already had a defective valve replaced, and I still have issues with the new shunt. My neurosurgeon thinks this is the right path, excuse me, but my symptoms are difficult to endure. In fact, last Friday when I was on this call, I had a severe episode of stuttering, severe headache, confusion, visual changes. I ended up in the ER, and my shunt has been adjusted 8 times in the 15-month period that I've had it. My question is, with each shunt adjustment, I get a few months of relief only. Why can't I get a shunt that offers long-term relief, or are there other options to consider? Thank you for taking my question.
Of course, and you probably know that shunts are very challenging in general. First of all, they're man-made devices that are prone to clogging or failure or infection. So I have one question for you, just to help me answer your question.
Mhm.
Where is the termination of your shunt? Is it in your belly or is it in your lung?
It's in my belly.
Have they ever looked to put it in your lung?
They have not.
Okay. So again, every patient with a shunt is a puzzle. And it sometimes takes many iterations to get the puzzle correct. And I think that one of the things we spend a lot of time doing, and actually Cynthia runs our hydrocephalus center here, is doing some of the tests, both with imaging, to make sure that the spinal fluid flow is working. So we all drain spinal fluid from our brain into our internal jugular veins, and that goes back to the heart. The amount of pressure that we have in our abdomen can actually prevent all of that from happening. So it's a hard question to answer over a computer, but it's an easier question to answer if I saw you in person, because I would need to know what the pressure is in the brain. I need to know what the valve that they're using. Is it programmable? Is it set at a certain setting? Where the termination is in the abdomen. So is it a right frontal shunt? Is it an occipital shunt? How your brain looks to your big ventricles, those kind of things. The one thing I want to reassure you is it's going to get fixed. They're going to make it right. It usually happens where at some point your body will figure it out. I will tell you that the most shunt revisions I've ever seen on a single patient was 75. So
Wow.
that's not to scare you. That's to actually reassure you that these are difficult man-made things where that was a child back at Children's Hospital in Philadelphia, and I saw him when he was 19. He had already had 75 shunt revisions. So just recognize that these are imperfect devices, but ultimately, and I think Cynthia or Olivia, we get it right at some point, but sometimes it takes a lot of changes of the valve. Sometimes it takes changes in the location where that's why I asked, sometimes we move it from the abdomen to the chest. Sometimes we move from the chest to the heart. We put shunts in just about everything. We used to put shunts in the gallbladder. We used to put shunts in the subgaleal space. So there are a lot of options that we can talk about, but it's not. It's very complicated, Janine, and we see many, many patients like you. And of course, we'd love to sink our teeth into you and help you in person, but it's going to take a little bit more information to help us do that.
If I would want more information and help from you all, well, I'm in Maryland too.
So we would need your CAT scans. We would need obviously the operative reports if you had an MRI of your brain, pre and post meningioma, or you get on the train and you come up and see us.
Okay.
Thank you. Appreciate that. Thank you,
Awesome.
Denise.
Thank you very much. I appreciate it. Thank you.
All
Wait,
right,
one
Nick.
last question. I'm sorry.
That's okay.
They ever try Diamox for you?
I couldn't tolerate it. I was up to 500 3 times a day, and I already had incontinence, and it was horrible.
Yeah.
throw
And
my
they
bladder
tell
off.
you you had papilledema or swelling behind the eye nerve?
No, I've never heard
Okay.
of that. I noticed I have had some vision changes recently, but they haven't really been addressed.
Okay. Have a good eye doctor check your vision too. Okay.
Okay.
All right,
Okay.
Angel.
Thank
Thank
you.
you very much.
Appreciate it. Next up is going to be Donna.
Hi, Dr. Boockvar. Nice to meet you.
Nice to meet you.
So I live in Raleigh, but I'm originally from New York. So I was diagnosed with I'm 2 years post-op, and I was diagnosed with a left frontal lobe meningioma. And so it was removed 2 years ago. I suffered a stroke during the surgery. And so I was left with right side paralysis, which after many months, I've gotten a lot better. But my question to you is, how common is it to have regrowth of the first tumor and then also to have another tumor occur?
So did they tell you what grade your meningioma was?
Yeah, it was grade
1?
2 atypical.
Did you get radiation?
No.
So if it's an atypical grade 2, and it's already been 2 years and it hasn't come back.
Yeah, but when the last time I went for my MRI, the radiologist thought he saw some kind of change. My oncologist said she didn't see it. So I'm going back in July for another MRI.
Okay. You have a slightly higher risk of it coming back because it's a grade 2.
Mm-hmm.
Doesn't mean you need more surgery, but if it does come back, you need radiation.
Okay.
And the benefit of the radiation is the grade 2s tend to have a higher what's called division rate. So the cells are dividing a little bit more quickly.
Okay.
And that's where radiation is effective. And so you want to be very careful about surveillance for you. Whereas a normal grade 1 meningioma, we may bring back once a year. For a grade 2, we bring back at least 3 times a year, every 4 months.
Okay.
Because as soon as we see a nodule, if it grows, we want to zap it with a beam of radiation.
Is there a certain, like, can you only have radiation once, or?
No, you can have it
Okay.
more than once. And
Okay.
you may get radiation either 1 day, 3 days, 5 days, or 30 days.
Okay.
If it came back, and that's a decision based on the location of where your meningioma is and other things. But I'm glad to hear that you got back your right-sided
Thank you.
strength.
Thank you so much.
So are we.
Thank you for that, Dr. Boockvar. Thank
Of
you.
course.
Thank you, Donna. Next up is Karen.
Hi, Dr. Boockvar. I'm Karen from San Leandro, California, and I'm a patient at Kaiser Permanente, which is one of the largest systems in California. I was diagnosed 4 years ago with a left temporal lobe meningioma, and I'm currently on watch and wait. I have many symptoms along with cervical dystonia. So I've been trying to get a referral to a neurosurgeon within the Kaiser system for nearly 4 years, but my primary care and my neurologist have both been denying my referral. So I've been seeing my neurologist for over 4 years, but neither physician will budge. So I'm feeling like a hamster on a wheel, and I'm not sure really how to fix this. So my question is, what recommendations do you have that may help me secure a referral to a neurosurgeon within the Kaiser system?
Well, not having any experience with that system, I don't know what their protocol is for why a neurologist is not allowed to refer to a surgical subspecialty doctor. Any of you have any experience? Is Cleveland Clinic like that? Olivia came from the Cleveland Clinic, so.
It's typically a little easier there.
Yeah.
But I mean, it's big.
Yeah.
Yeah.
One thing we can do potentially is, if you wanted to email me the neurologist that you're working with, and we can just politely reach out by email and just nudge them. Doctors don't like to be nudged. So when we're nudged, we tend to say, all right, we'll do it.
Okay.
But it's a little bit of unusual. You're entitled to see a surgical subspecialist, particularly if it's since meningiomas is a surgical disease. Surgery is curative for the majority of meningiomas. So, obviously I can do we can actually do what are called educational visits. If you packaged your material and sent it over to us, I do have to charge you for a fee because Medicare requires that I actually bill you like I'm seeing you in the office. we call them educational visits because technically I'm not licensed in California. But what you can then do is bring that to Kaiser and say, look, at least you have a recommendation. That's an option.
Okay. Okay.
I
Okay.
can't
That
do it.
sounds,
It's illegal for me to do it for free.
got it. Got it. Okay. That
It's
sounds like
actually
a
not
good
Medicare
plan.
compliant. I have to charge you as if I'm looking at you in the office.
Okay. Okay. Sounds
That's
good. Thank you.
really good to know. Thank you for that
Yeah.
resource
Yes,
for educational visits. You know,
Yeah.
people would be, a lot of them very happy to pay just to have a second set of eyes on
Yeah.
their condition. So that's
Yeah.
really good to know.
Yeah. Yeah. Thank you so much, Dr. Boockvar, and happy birthday tomorrow.
Oh, thank you.
Thank you, Karen.
Thank you.
Next up is going to be Elizabeth.
Hi, my name's Elizabeth. I'm from Fort Myers Beach in Florida. I'm 2 years post-surgery of a left brainstem meningioma. They debulked it because they couldn't remove it. 6 months later, they did a gamma knife on it. I had 5 treatments, and I lost my hearing in my left ear completely, and I have trigeminal neuralgia from the surgery. In total, I have 4 meningiomas. Recently, the one in my right optic nerve was growing, and they found out in 2 MRIs in 9 months that it started growing. So they did another gamma knife on the one by the right optic nerve. My question is, as tumors grow, how often can surgery actually be performed, and how often can you have gamma knife on the same tumor?
Well, just to answer the radiation question, we don't like to radiate anything that's been radiated within a year. That's our general rule. You have to at least wait a year to re-irradiate something. And of course, re-irradiation, every tissue has a maximum number of gray. That's the unit of radiation that it can take. So every tissue is a little different. For example, the optic nerve cannot take as much radiation as the cortex of the brain. So it depends what we're radiating to answer your question. But you can re-irradiate something, but then there's a maximum dose a tissue can tolerate over your lifetime. And surgery, like I said before, is always the treatment of choice for meningiomas as long as the neurological risk to the patient is not significant. So we weigh that, whether it's the brainstem, the hearing nerve, we try to do surgery as long as it's not a high risk for the patient neurologically.
Yeah, that's why they did gamma knife on the one by the right optic nerve, because they said it was a high risk to do surgery. And so they went with the gamma knife.
And that should have a 90% success rate at controlling your meningioma.
Okay.
So 9 out of 10 times, gamma knife alone will stun the growth and prevent it from growing.
Okay, that's good to know. Thank you very much.
Of course.
Thank you, Elizabeth. Pam, you are next.
Hi, I'm Pam, and I'm from Pennsylvania. I was on watch and wait for 2 years, decided to have surgery in October of 19 at the Mayo Clinic, because even though it hadn't grown, I did not like the fact that I had a tumor in my head. It was about 3 by 3 by 2. My primary symptom was very, very stiff legs, and my tumor was found incidentally. So due to its location, it was only partially resected. I still have over half of it, and I have worse symptoms. My legs are still very stiff. I also have a shunt. Now I'm treating with a neurologist and a physiatrist. Physical therapy did not help. I'm on Boockvar, it does nothing. And my question is, I just wonder if the surgery could have made the tumor and the symptoms worse. I get my periodic MRIs, and thank God it has remained stable. But my quality of life is not good right now.
Pam, where do you say the meningioma was located?
It was, I'm sorry, it was skull base, and it was posterior to the lower clivus and anterior to the medulla and lower pons.
Yeah. Well, that's a challenging location because, and your incision is behind your ear?
Behind one ear, and my shunt is behind the other.
Yeah,
I was left with double vision. I have to have surgery on June 30th,
yeah.
paralyzed vocal cord, and a host of other things. So, needless to say, why did I have the surgery? I don't know. I'm still asking myself that question. Thank you for your time.
Yeah, no, and it sounds like you have something called a petroclival meningioma, which is the hardest of meningiomas to treat surgically because the nerves are running right through it, the cranial nerves.
Right,
Um,
right.
And so you do the best you can in taking the tumor out without hurting the cranial nerves, but it's high risk. And vocal cord paralysis is common and some weakness on the other side and double vision. So I have a good picture of what's left in your head. Now they took 50% of it out, which is helpful. And
Not quite, yeah, but close to.
but they took enough out where the volume of radiation is a little bit less, and you should have good control from here on out. Again, these are hard tumors, and they're hard to take out surgically. Where'd you have the surgery done?
Mayo Clinic in Jacksonville.
In Jacksonville. Well, they have a great group.
He was a wonderful surgeon, Dr. Quinones.
Yeah, I know him well.
Yeah, he was.
Yeah.
And he
Look,
worked on me for about 10 hours. And my husband said he was pouring down sweat. Yep.
Yep. You can be the world's greatest neurosurgeon, and they're challenging tumors. So he's a great surgeon, and I'm sure he was just trying to keep you safe. And this location of this kind of tumor is treacherous. So with the double vision, I hope the surgery goes well with your eyes. And you wearing a patch at all, or prisms?
Prisms.
Yeah.
But they're not. I mean, I'm just like a couple of the other girls. My vertigo from the prisms, and I was left with terrible vertigo after surgery.
Yeah.
And I still struggle with it every day. I don't know why, but I do have it.
You had radiation, you said?
No, I chose not to.
So radiation may help some of those symptoms, actually.
I'll think about that. I have my disc, I'm forwarding it, and spoke with Elizabeth through Angel. I'm very thankful to her. I'm just in the process of obtaining my MRI with another facility to send. And she thought maybe, I could set up some kind of an appointment virtually and maybe get some insight into what I can do.
Yeah, I'm going to send Angel Dr. Boockvar's information of where to send all the disc and the information. Once we obtain it, he reviews it. They'll set up an educational visit. That's not a problem.
Perfect.
Thank you.
Thank you, Cynthia.
No problem.
All right. Thank you, Pam. Next up is Allie.
Hi, I'm Allie. I'm from Nashville, Tennessee. I'm actually 5 months post-op of a left posterior fossa 7-centimeter meningioma grade 1. When I was diagnosed, I was actually going through my second round of IVF. My symptoms came of the dizziness, nausea, migraines, double vision, and inability to walk came all suddenly. Fortunately, I'm doing better, but tired easily and have some deficits. My question is, I had no hearing issues pre-craniotomy, but afterwards, I can't hear out of my left ear. The side of the tumor was resected from. My neurosurgeon suggested vestibular therapy for all my vision problems and the dizziness, but my neurologist that I had just recently seen last week said that possibly in surgery, they lightly damaged the 8th nerve and no amount of therapy will actually help. What are your thoughts on restoring my hearing and managing my dizziness?
Allie, can you smile for me? So you have a perfectly pretty smile, which is really tells me about the 7th, 8th cranial nerve complex, and that your 7th nerve looks near normal.
Okay.
And so has the doctor talked to you about a cochlear implant on that side?
Yes, but he said he can't refer me until 2 years post-op.
Interesting. So the answer is the nerves heal a millimeter a day. That's the speed of which nerves heal. That's a very slow process. So do you have any hearing at all in that ear?
No.
So if you tap the bone behind your ear, do you hear it?
No.
Have you seen an audiologist, a hearing doctor?
No. The only person that my neurosurgeon has referred me since is just the neurologist, because my headaches has came back, and then also my dizziness has gotten worse.
And you don't have a shunt or hydrocephalus?
No.
How many weeks out are you?
I'm 5 months post-op, but pre-craniotomy, they only saw a 4 centimeter meningioma. But when I went in, it ended up being a 7 centimeter.
And you didn't do a scan the morning of surgery?
I did.
They did, okay.
Mm-hmm.
And it was grade 1?
That's what they said, yes.
So.
But there's still 3.3 millimeter either regrowth or left. He doesn't, feels like it might have been like inflamed, or, you know, he doesn't know, or he just left it there because of the position of where the tumor was.
And you should be getting a 6-month MRI scan soon, correct?
Yes, I'll get in September. I just had a CAT scan to go see my neurologist, and they said everything is fine. But also my neurosurgeon, he's kind of like a happy-go-lucky guy. So he's like, everything's fine all the time. But my symptoms had just gotten worse.
Yeah, it sounds like, so one thing I would recommend is see an audiologist, like a hearing ENT doc. Get a good audiological exam, a hearing test. Because that will tell you if you have any nerve, if the nerve is intact, then you would benefit from a cochlear implant.
Okay.
And that's something to consider. Now, at least you can start that process by having, if you were here, I would send you to our neuro-otologist, which is an ENT doc that specializes in hearing.
Mm-hmm.
And for example, he would do a full hearing test. He may help you with vestibular rehab and some vestibular exercises. And of course, seeing your MRI scan and making sure you don't have hydrocephalus, which you've heard talked about, which is not uncommon in meningioma patients.
So who would I ask?
Your neurologist.
The neurologist. Okay, so he said he hasn't seen my MRI scan. So the next time when I do get an MRI, he'll say he'll go through it with me.
Yes.
So yeah, so it should be coming up.
And do you see your neurosurgeon still?
I haven't seen him since what, two months after post-op.
Yeah, I mean, I would make it an appointment to see the neurosurgeon with your September MRI scan. With the question is making sure you don't have hydrocephalus.
Hydrocephalus, okay. And then with you said with the ENT doc, would I get that from a referral from my neurosurgeon or from my neurologist or my PCP?
I would say the neurologist.
The neurologist, okay, because all he has done right now is giving me some medication for my headaches, and then he's just gonna wait until I go back for the MRI to do anything else.
You could also ask the neurosurgeon. I wouldn't say the PCP, just because.
Okay.
They're not, you know, I would say either the neurosurgeon or the neurologist. They shouldn't think twice about it.
Okay, because I asked cochlear implant or like, you know, get the referral, but he says he just has years.
Well, why don't you start? Let's ask that question of the neurotologist that you end up seeing.
Neurotologist, okay.
She needs the referral.
But you'll need a referral from the neurosurgeon or the neurologist.
Okay, so I could contact with them. Okay, do you think anything will help with the dizziness? Because I am doing two times a week vestibular therapy, and I'm usually down for 2 days.
When you say dizziness, is the room spinning or you're lightheaded?
Both, and I feel like vomiting. So I right now cannot turn my neck left or right too quickly, or even just looking over my shoulders, because it just causes me to have really bad dizziness.
Are you on compazine or something like that?
No, they gave me meclizine and they gave me a scopamine patch.
Yeah, that doesn't help, does it? Are you doing positional vertigo exercises?
Like what does that entail?
When you lean your head over the edge of a bed and turn it to one side rapidly?
No.
I want you to see a neurotologist. Part of this is positional vertigo. And when you say you spin your head rapidly, then things start spinning?
Yes.
Yeah, that's BPPV, benign paroxysmal positional vertigo.
Oh, wow.
And there are exercises that you can do.
Okay. With my therapist now?
Well, you can bring that up with the therapist now, the vestibular therapist.
Okay.
You should be doing that. It sounds like that's what it sounds like to me.
Okay.
I have to dig deeper, Allie.
Neurotologist is going to be important for you.
Okay, perfect. Thank you.
Our pleasure.
That's awesome. Thank you for all that advice. Thank you, Allie. I'm last up. I have been on this journey for 10 years. I'm 3.5 years post craniotomy. I'm really very much a textbook recover patient. I never had a single symptom going into surgery, and I don't have any deficits post. So I've been very fortunate, although this journey creates a lot of fatigue and anxiety and worry year to year with MRIs and things like that. I have been very fortunate that the 2.1 centimeter meningioma above my motor SSS, attached to the SSS nerve, which was why they decided to take it out after all those years on watching weight. But they had a 99% resection. Unfortunately, maybe we should have taken it out a little sooner, because once it kind of latched onto that vein, I guess that's when it was like high risk had to come out. But again, doing really well and very fortunate in that regard. But my question is, I had my surgery, my craniotomy so young in my early 40s. Do I need to be worried about any parts and stuff that are in there 20, 30, 40 years from now needing to be replaced or checked in on? I don't know what the shelf life of this stuff is. So any things I should be watching out for? And I hope I don't get a reoccurrence, but I guess it's possible.
So the answer is, yes, you always have to be cognizant. We see, unfortunately, as we all age, as my birthday comes tomorrow, our scalp actually atrophies. We lose some of the fat content in the scalp. And of course, our skin changes as we age. And so some of the titanium devices we use to hold the bone together can become more prominent depending upon where your surgery was. So we will commonly see women in particular who have less scalp fat. For example, if they've had a meningioma removed on their forehead or in their temporal area, and that area atrophies as they age, doesn't mean it's going to happen to you, Angel.
Yeah.
But you can see screws and plates, and many of you can probably feel your screws and plates now.
Yeah, I can feel the little.
And that may become more prominent as you age and as your scalp thins. And in particular, if you get radiation for that accentuates the process. And on that note, we have created a field called neuroplastic surgery. And our Brain Tumor Center actually just launched our neuroplastic surgery program with a new faculty member from Hopkins to address your very question, Angel, that neurosurgeons tend to be, let's go in, let's run quick, let's get the tumor out, close it, let the fellow or resident close the scalp and blah, blah, blah. And we found that that's not adequate because we weren't really taking into account I don't want to say the cosmetic component and the healing component. And so neuroplastic surgery is a big part of what we do now, where we integrate, make sure that you all look as good now as you did before you had brain surgery and radiation for this. And so the answer, Angel, is keep a close eye on it. If it starts to bother you, that's real. And we have to, I just saw a patient on Friday, Olivia, I think we saw, do you see the liposuction patient? So a woman who I took a meningioma out in 2012 was developing pain behind her ear from a screw. We sent her to a plastic surgeon who did liposuction, took out fat from her, wherever her source was, and injected it like she was getting butt filler on top of that plate. And she has relief for 3 years now from pain. So we're doing some innovative things. I'm not saying that's going to work for everybody, but the whole idea of this neuroplastics approach is an important one, and I can't emphasize it enough. So I'm glad you ended on that that question.
Thank you. I couldn't really think of a question, and I thought I'm always shampooing my hair and I'm feeling the little bumps, and if the weather gets cold, it feels really tight, and I just thought, I wonder, how does this move change with the bone growth? Do I need to be concerned about anything? So
it's not something to be concerned about, but you're surely in the
attention.
majority if you have some discomfort related to it. Many of our patients do.
Yeah.
And it's my
you
job.
never forget it's there. That's for
Yeah,
sure.
I mean, well, that's actually one of the reasons why we've launched this neuroplastics program is we want our brain tumor patients to forget about the fact that they've had brain surgery, and women in particular who have nice hair, and you're looking in the mirror all the time. It's a constant reminder of this process. So our goal is to help you forget about it.
Well, we appreciate it. All of us, and
Very
we have
much.
our sessions every week. Very often the question comes up, how do you forget about this? How do we
Right.
move on from this? It really is with us every day, and not in a negative way. We all feel very grateful to have survived this and, get along as well as we do. But just knowing there's MRIs looming, just knowing if you have a headache, your first thought is, oh crap, the tumor is back. It's just not something we can really easily let go of. So we work together to learn how to embrace it and laugh about it, and just kind of celebrate the wins every time we get those clean MRIs, and nurture each other through the symptoms that do seem normal. And of course, help send our friends to the doctor when we feel like things are not good. And just kind of be companions for each other on this really crazy journey. But truly can't thank all of you enough for the work that you do, and just taking time with us today to answer our questions. That really is admirable, and we so appreciate it, because a lot of us do not feel heard, and it's nice to be comforted and hear from you guys. Get some really good advice. I obviously want to be aware of the time. I know you guys have work to get back to. Dr. Boockvar, is there anything that you might have for us that you would like to ask or add?
So we have many patients who would benefit from a group like yours. How do we get them involved in your groups?
Yeah, so braintumorcompanion.com is the website. You can also look up meningiomacompanion.com. They both go to the same place. I did send an info sheet to Cynthia. Hopefully you got it. I can re-email it. It's really, I can send an updated one. I think it might have changed a little bit, but all the information is on there. The links are on there. Anyone who could use this support on your end, send them our way. We'll welcome them with open arms and hugs, and it's a very soft place to fall. There's also a lot of good resources on my website. So however we can help, we are certainly happy to do so.
And vice versa. If any of your patients want access to us, Tamika runs our clinical trials office either through clinicaltrials.gov. Just email us. We will see anybody across state lines and can offer an opinion. And then, of course, if anyone who's welcome to come to New York. But if any patient sends us their film and sends us their reports, we're able to render an opinion. The terminology has to be changed to an educational visit, but we do it across the country, across the world, almost every day.
I love that so much.
And then if any of you have problems with your incisions or your screws or your plates, or you just don't feel like you look right, I can't emphasize enough. We just recruited a superstar who is an expert on that. So if you feel like something's wrong, like I said, if you see something, say something. Come to New York and get it fixed. Don't look in the mirror and see a divot or an atrophy or an eyebrow that doesn't go up, or that's stuff that we feel very strongly about, and we bill it through your insurance. These are not cosmetic. That's not even that woman with the liposuction got it fully paid for by her insurance provider.
Nice.
Wow.
Yeah, I would love that information and contact, and I'm happy to put it in my newsletter on my website. I think that so often we feel a little insecure about what we've gone through and what's left of us afterwards. So having that on hand, that resource would be really great to share with people.
Great.
Awesome. Well, thank you so much, everybody.
you.
It has been a wonderful hour together, and really appreciate your time. You guys are doing great work at Lenox Hill, and we can't wait to watch season 2 of the show.
Yeah, well, he's
Thank you.
Thank you.
Birthday.
That's
you very
right.
much.
Have a
Thank
good day.
you.
all right.
Take care.
Thank you.
Bye-bye.
Thank
Bye.
you. Bye-bye.